Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good morning, everyone. My name is W Chang. I'm at the University of Chicago. I'm the professor and the chief of plastic surgery here. First, I would like to thank the Lymphatic Education and Research Network for organizing this symposium. The topic I want to share with you today is an update on lymphedema surgery. So a lot has happened over the past decade in terms of understanding lymphedema and different types of surgical procedures. Also, there have been many publications on this topic, so I'd like to share that with you. I'd like to thank the sponsors who make this symposium series possible. This is a disclaimer from the LE&RN. My personal disclosure. So today, this is kind of an outline of my presentation. I'll talk a little bit about history of lymphedema, current surgical treatment options. I want to talk a little bit about the published studies and my personal experience doing this for now over 15 years. So lymphedema can occur whenever there is a failure of the lymphatic system. And worldwide, over 250 million cases of patients are affected by this. It's probably even more than that, as many are underdiagnosed. Lymphedema cause can be what's called primary, meaning that the patients are born with some sort of abnormality within their system. And the lymphedema can then manifest at different times in their life. So some can be born with it, some can develop it during their childhood, but more commonly it develops later on when the patient is a young adult. A lot of the cases that we see are secondary. So patients develop lymphedema secondary to a surgery, removing the lymph nodes, or radiation to lymphatic area, or parasite. So a parasite called filariasis is very common if you go to a certain part of the world, Southeast Asia, or in the Africa area. These are parasites that get into your lymphatic system that obstruct the lymphatic system physically. It's rarely seen in the United States or in the Western countries. In the United States, most common cause of lymphedema is secondary to breast cancer. When the lymph nodes are removed, even if just the central nodes are removed, there's a small chance that you could get lymphedema. And the incidence is quite high, higher than all these other diseases combined. This is a paper that was published a while back that looked at the various different factors that are associated with lymphedema, such as obesity, the use of radiation, the age of the population. And we know that the trend is that all these factors are increasing. People are living a lot longer. There's a lot more radiation use for treating cancers. And as a population, particularly in the United States, has become more obese. So the expectation is that the incidence of lymphedema probably would increase over time. And it is very debilitating. Only people with lymphedema will be able to tell you that. It's not just heavy. The arm or limb is heavy, it's swollen, it's deforming. Actually, it can be very painful. You're prone to developing infection. And it's a lifelong problem. It's a disability. It could be a financial burden to patients. Unfortunately, there is no cure. while it's poorly understood, I think this area is continuing to get improved as there has been a lot more meaningful research in this area. We are trying to understand this better and better. So what do we know about lymphatic system and lymphedema currently? Well, actually, if you go all the way back to Hippocrates, he even mentions something about lymphatic system in one of his writings. And Galen, a Greek physician, also described that in some of his work. And the anatomist Aselli from Italy describes a lymphatic system in some of his other works that he did in animals. But a lot of the anatomy of the lymphatic we understand now comes from the work that was done by Sappi, a French anatomist. He used the mercury, which was actually really good at identifying lymphatics, but it's toxic, so it is no longer used. What we know is that lymphatic system is very similar to our blood vessel system. The lymphatic capillaries are under the skin. They drain to lymphatic vessels. They're in the subcutaneous tissue, which I will talk about. And there are also lymphatics much deeper between the muscles. They eventually all drain into the venous system. On the left side is a thoracic duct, which drains about 75%. And there's also a duct on the right side, which drains about 25% of the lymphatics. It is a dynamic system. So there are muscles, smooth muscles within the lymphatics that pump the fluid distal to proximally, and there are valves in there so that the fluid does not back up. And this is a very important mechanism because in patients with lymphedema, these mechanisms can be lost over time, making lymphedema even worse. So damage to the lymphatic system leads to increased pressure, which leads to inflammatory process, which lead to deposition of fat, tissue fibrosis. This causes more increase in pressure. So this is a vicious cycle. So the procedures that we are doing now in terms of lymph node transplant, lymphovenous bypass, is to break this cycle. Because if you don't break this cycle, lymphedema will get worse over time. So there are three components to the lymphedema. Excuse me. Certainly, fluid is very common. That's how it starts. But then over time, there's more fat and there's fibrosis. So again, it leads to the pumping abnormality as the smooth muscles are destroyed and lymphatic fibrosis and leak. And then you get what's called this small lymphatic capillaries that develop and the impaired collateral vessel formation. So this is a cross-section of the lymphatic vessels seen under the microscope. This was studied done by Koshima, published in 1996, looking at the smooth muscles within the lymphatic vessels. And this is how it looks in patients with lymphedema. Look at the difference. The lumen is occluded in this one, and even ones that with the lumen still intact, most of the smooth muscles destroyed, meaning that lymphatic vessels are no longer functional. So when I do microsurgery, I find lymphatic vessels on the microscope, and they have variation like this. I've seen all these kinds of different lymphatics. So this one, it still has some fluid in it and working, but start to have some damage. And over time, this damage becomes worse and worse. And even if the lymphatics are still there, it's not working at all. There's no fluid in there. It's not pumping. And these lymphatics are not functioning. Now, medical treatment is very, very important because even in successful case after the lymphedema surgery, patients are still going to have lymphedema of a certain degree and have to maintain lifestyle to manage the lymphedema better. Top of the list is weight control. We all know, and everyone agrees that the heavier you get, the harder it is to manage lymphedema. So the weight control has to be is a key. Even in patients where we do surgery and they do well, if they present later and they have gained a significant amount of weight, a lot of the effectiveness of the surgery can be reversed. There are many studies that show that exercise is actually very good. Any kind of exercise is very good. in helping pump the lymphatic fluid out. But particularly any aquatic exercise out on the water has been shown to be very effective. And of course, I think lymphedema patients all do this already, but doing various different types of lymphedema therapy, compression, garments, and obviously making sure that your hands and feet are always clean, are not traumatized, not cut. So wearing a garment, wearing some sort of a protective glove or socks or shoes is very important, because once you get infection, your lymphedema really is really blows out of proportion because of the infection causes inflammation, and you really want to avoid infections. And it's hard to get rid of infections once you get them. So surgical treatment can be divided into surgical excisional procedures and physiologic procedures. So this is what we commonly call a Charles procedure, where you excise a tissue and then skin graft. Described 1912. Gillies operation, where you take a skin flap and then you place into the lymphedema with the direction of lymphatic vessels going this way to drain the lymphedema arm. And lymphatic bypass, where you take a normal lymphatic from one side and then actually kind of bypassing the area. So these are procedures that has been described in the past, not commonly performed now, except in rare situations. Two most common procedures that most people do now are lymphovenous bypass and lymph node transplant, or variations of these two procedures. So lymphovenous bypass is a simple concept. You're just creating a detour of obstruct lymphatic into an open venous system. Described actually in an animal model back in 1960. And then another description of connecting lymph node into a vein, described in 1965 by Polish group. More publication about various lymphovenous bypass. This from Australia, 1977, 1990. So these have been described before, but using the older techniques, and never really became popular or mainstream, because many people felt it was not really working. But many advances have been made in surgery, microsurgery, with a better equipment, better microscope. We are able to do surgery in a smaller vessel. So in 2000, a certain description of lymphovenous bypass was described, connecting lymphatic into a small veins, because what you want to do is connect high pressure lymphatic into low pressure vein so that the fluid can escape. And it makes sense, because fluid will drain through the pressure gradient. If you go from high to high, it's not going to drain that well. So with the modern microsurgical techniques, we're able to do this. So this was my earlier first publication. I started doing this in 2005, making small incisions like so, all done on the microscope. Find a little lymphatic right there, you can see clear, and then connecting into a vein that is also nearby. These are very small, 0.3, 0.4 millimeter in size. And you can see there's vein here, there's no pressure coming out. So we connect these, and then the lymphatic fluid from the lymphatic will go into the vein and drain. But it was hard at the beginning, because we didn't have the proper equipments and the microscopes. We were just using standard microscopes. And then we measured the patients using a parameter, which some centers have it, but not everyone has it. It's a good way to measure the lymph volume. And then I published a result and also presented at a national meeting. And it was preliminary data, about 1 year follow-up, showed a significant improvement after bypass. And it turns out that one of my patients, the earlier patient that I had performed, was a big advocate. I was behind the scenes. I didn't even know, but she was telling all the other patients how the surgery really helped her. So patients started to call. I used to be working at MD Anderson Cancer Center at the time, start to call to see if they can get the procedure as well. Now, one of the challenges at the time was finding these functioning lymphatic vessels that I talked about. because you got to find the lymphatic vessels that are still functioning for the bypass to be effective. So this company from Japan approached me. I found out about this device that can allow us to see lymphatic vessels using the indocyanine green, which is a dye that's commonly used in the surgery and are available in most hospitals. So you inject a dye and it goes into the lymphatic system, and you can see the lymphatic systems, functioning lymphatic systems. It's very, very helpful because once you inject it and using a special kind of camera, you could map out lymphatic system in the arm or the leg. So this isn't in a normal arm or the leg. And here is an example with a lymphedema patient. You can see this is what we call dermal backflow. A lot of lymphatic vessels have become hypertrophied, but not really functioning well. And here's some functioning lymphatic vessels, but then you don't see anymore. They're probably already damaged. So I would bypass them in this area, but I would know exactly where to make an incision and do the bypass. So here's some other images you can see, various images. Here's the hand over here. You can see lymphatics here. It's all backed up here. So then I would bypass somewhere around here. There's another lymphatic going here, and then all of a sudden there's all damage. So I would bypass here. So you can imagine this like a traffic. Cars are flowing, traffic jam. You bypass here so you can get out of traffic. So here's a lymphatic vessel, traffic jam. You bypass over here. So here's a lymphatic where lymphatic actually doesn't back up at all. It goes all the way into the axilla. So I do not bypass these. If there's no traffic, if you're driving and moving fast, why would you detour? So only thing I can do is make it worse. So these kind of lymphatics, I do not bypass. So this technology really made surgery easier. Finding functioning lymphatic vessels became much more easier. And instead of making incisions all over the arm or the leg, you could make it exactly where you need to go. And another thing is that it can help us confirm the patency of bypass. So patients often ask, how do you know that your bypass is working? Well, because under the microscope, we can see them. So now we have a lot of advances in the equipment, some really more advanced microscopes, advanced instruments, advanced sutures that are designed specifically for lymphedema surgery. These were not available in the past. So here's another picture. This is all under the microscope. You make an incision here, and then you go through the tissue to find the lymphatic vessel. And I'll just fast forward here, and you can see under the microscope the lymphatic vessel that's functioning with the ICGN. Then and then we will bypass that. So here are some lymphatic vessels seen, very clear. If you do not know what lymphatic vessel looked like, you may not even notice it. So here's a lymphatic vessel. Here's two of them here, a little bit damaged, but still functioning. And we also inject blue dye, which go into lymphatic vessels, and the lymphatic turns blue, making it easier to identify. So once we identify it, then we have to find the vein, and then we bypass it, like so here. So here's a lymphatic. What you will notice is that this lymphatic has a lot of fluid coming out. You can see it's all filling up here. All the clear fluid coming out here, that's all lymphatic fluid. If it's not bypassed, it gets trapped in your tissue. And here's a vein. You can see there's no blood coming out of the vein. It's important because you want the fluid go from here to here. And you will see shortly after we complete the stitching that the fluid is going from here to here. So when I squeeze the fluid out of the vein, you will see it's filled immediately by the fluid. See that? That's fluid is going from here to here. Those are the kind of bypass that can be very effective. And this incision is only like about 1 inch, small. So here now I'm trying to squeeze blood from the vein into the lymphatic, and because the pressure is so high, it doesn't get backed up. So eventually this blood will all get drained out, and the lymphatic will be draining this way. And under the microscope with the ICGN, you can see the dye go from here to here. So you know it's patent. So it's important that every bypass is patent. If you do anastomosis, and if it doesn't work, then it just, it's not effective. And different views showing the dye go from vein into the lymphatic to the vein. You can see flowing in there. These are what we call end-to-side anastomosis. When the vein is large, we go sideways. If they're small and similar size, you go end. So that there are various different techniques that are developed depending on the size of lymphatic and the vein. Then I published this, already been over 10 years, 100 consecutive cases. Now, of course, we've done a lot more than this. They used to work with, we used to be colleagues at LE&RN. And then we staged it using the ICGN, looking at various different. So earlier lymphedema would look something like this. Relatively good lymphatics, still some backed up. For those with more severe lymphedema, will look more like this. You find very few, if any, lymphatics, all dermal backflow. These patients don't do well with lymphovenous bypass because you no longer have a functioning lymphatics. So it is important that you go and have the surgery done earlier on. If you're more advanced, the results are not as good. And I think everyone kind of agrees with that. And these are some of the research that been done, looking at different type of tissue factors in patients with lymphedema, and these are all elevated. So we did a study where we took the tissue from the lymphedema arm and the normal arm, and we measured these factors before the bypass and after bypass. What we wanted to see was whether after bypass, these factors would go down as we would expect. So as you can see here, this is a normal side. It doesn't change. It shouldn't. On the lymphedema side, elevation has come down significantly, but not to the normal level. It's still elevated, but not as much as before, showing that the lymphovenous bypass can be effective. Now, lymph node transplant is another technique that has become popular. And originally, I was somewhat skeptical of a lymph node transplant. I was not sure how it worked and what the potential complications are. So again, this was first described in animal models going back to 1979, and again in 1990. But one who really kind of started publishing about clinical cases was Dr. Corinne Becker from France. This is one of our earlier patients with lymphedema of the arm, where she took lymph nodes from the groin and then transplanted the axilla. After a few years, you can see some activity that show up that was not present before. And the idea is that once you put lymph nodes in, over time they develop lymphangiogenesis, meaning they sprout new lymphatic vessels, like planting a seed, and connect with the existing lymphatics. The concern that I had, and many people have done as well, is that what if you take lymph nodes from these areas? What if it causes damage, causes another lymphedema? And over the time, we begin to better understand how lymphatics drain. So when you take lymph nodes from the groin, we got to stay away from the medial portion, stay laterally, because lymphatics from the leg drain into the medial lymph nodes. So understanding the anatomy is very, very important when you're doing lymph node transplant, or any surgery for that matter. So this is a study that was done in Finland that's showing the patients who had lymph nodes taken from the groin, and these are the 13 patients where you can measure what's called the transport index. That's the speed and how the lymphatics drain. Now, none of these patients had developed lymphedema, but in patients where lymph nodes were taken out, many of them had reduced speed slowed down, meaning that over time, it's possible that they may develop lymphedema of the leg, especially if they get an infection or something happens. So it's very important that you understand how the lymph nodes drain and how to do the surgery properly. And this is a study that was published in Europe, not by surgeons, but by therapists, where a lot of patients who had lymph nodes removed showed up in their clinic with the problems in the donor site, where the lymph nodes were removed. So certainly understanding the complications of surgery is very critical. And if you're seeing your doctor, they should share that with you. So this is probably the first patient I've seen who I did lymph node transplant. This patient had very severe lymphedema, as you can see. The tissue is very hard and rock hard. It's not a candidate for bypass. This patient would not have any functional lymphatics left in this guy. And he actually wanted the leg amputated because it was so debilitating for him. So I decided to offer him lymph node transplant as a resort, just as last resort to see if it could be helpful. So I thought maybe taking lymph nodes from the supraclavicular region might be helpful because we know that these nodes will not cause any secondary lymphedema. And this is something that we've done quite a bit when we're doing head and neck reconstruction. So I took the nodes from the supraclavicular region and transplanted to the ankle. And this is 3 months later. This is no liposuction, no excision, just lymph node transplant only. And you can see it's still large, but it's gotten a lot softer, not smaller, just by doing the lymph node transplant. So these are some of the lymph nodes that are commonly used now. And groin lymph nodes, thoracic, neck, supraclavicular, submental, omentum, mesenteric nodes. These all developed because of the concern that taking the lymph nodes from the groin or thoracic area may cause lymphedema of the arm or the leg. I use mainly groin lymph nodes when I'm doing combined breast reconstruction with the abdominal flap, lateral thoracic nodes for upper arm lymphedema, supraclavicular lymph nodes for lower extremity, sometimes omentum if none of these are available. So this is a neck, this is a clavicle, and the incision here is about 2-3 inches long, usually heals very nicely. And we take, you can see the donor side, you can barely see the scars. This right here, I'm unless I point it to you, you probably can't even see. This one you can see. But these are about all year out. And then we reported 100 consecutive cases of donor site morbidity. And we found that in 3 of them, we had to go back in because of hematoma or something. And there was a little bit of colic in 2 patients, which stopped by itself. Infection, no secondary lymphedema of the arm. So, and another lymph node I take is from the back. The lymph nodes called lateral thoracic lymph nodes. The small amount of muscle, most of the muscle are left behind. So we'll just take a little bit of lymph nodes here with tissue, and then we swing it up into the axilla, fill out the scarred area, and then provide lymph node transplant to the arm. Now, sometimes I have patients who present with no breast after mastectomy and lymphedema. And all these patients, the main concern is not the absence of breast, but lymphedema. But there's a solution actually that we provide that can do breast reconstruction and lymphedema at the same time, treat the lymphedema at the same time. So this is combined breast reconstruction lymph node transfer. So this was described in Europe, where DIP flap, this is a commonly used flap reconstructive method for breast, where we take skin and the fat from your tummy. Essentially, it's a tummy tuck, but we use that tissue to make a breast with. Now, underneath it are the lymph nodes in the groin. And if you connect, take one of the blood vessels that go into this lymph node together, you can take lymph nodes and the skin and the fat at the same time to make breast and also perform lymph node transplant. So here again, other lymph node based on these vessels that are called superficial circumflex vessels. So you take abdominal tissue and lymph nodes, and then you transplant it. And here are some of the data they published, 9 patients that they did, showing that before the surgery, there's no activity at all. This is a lymphedema arm. This is normal side. Activity shows as a good lymphatic function. And over time, you can see some new activity developing. And very promising 6 months after. So this is one of my patients who presented with the absence of breast and severe lymphedema. She's had for 12 years. So we take abdominal tissue. There's some illustrations showing the various different techniques we use to perform this procedure. And we take tissue from the abdomen to make a breast, and then we take lymph nodes and put them into the axilla, and then we connect the blood vessels there. And this is how she would look after initial surgery. Now she has a breast. We will have to make a nipple for her, which I often do that in the office, and then lymph node transplant in the arm. And it has been very successful. Now, many people are wondering, well, do these procedures work? If they do, which one is better? When should I get lymph node transplant? When should I get lymphovenous bypass? So I know there are many questions here. I see in the chat box and the Q&A, and I will answer this at the end. I was told that if you have questions, you should put in the Q&A box so that you know, not in the chat box. So this is what we call systemic meta-analysis. This is where we look at all the published data that's out there and we analyze them. And we looked at all the published data regarding lymph node transplant, lymphovenous bypass, and analyzed them to see how accurate the data is. And these are the co-authors who I worked with, many of the names who you probably are familiar with. And actually this got the best paper award. So we looked at thousands of papers, and we identified actually less than 100 studies that actually meet the quality that are worthwhile analyzing. We found that there's evidence support that both lymphovenous bypass and lymph node transplant can be effective in reducing the severe lymphedema, but none of these are cure. They will not cure lymphedema. So if you're looking for cure, that's not going to happen, but it can make it better. It can make your lymphedema better, so it's easier for to manage. And there's no data to say one is better than the other. But what we do know is that timing of how these work are different. Lymph node transplant, because it works through lymph angiogenesis, it can take time. They don't work immediately, although if there's a lot of scar tissue, for example, in the axilla, and you release them, you may get improvement from that. But lymph node transplant takes time, especially if I put them in the leg. Sometimes I don't see the result for like 2 years. It takes time. Lymphovenous bypass, if it can be done effectively, the results can be immediate because you are diverting the excess fluid. But this is not available for everybody. You have to have a good lymphatic vessels for us to be able to bypass. If your lymphedema is already advanced, and if your lymphatics are already all damaged, then we really cannot do any bypass. Or if you do the bypass, it'll just be it would have been a wasted procedure. So I start to combine them. I start to offer both same time. The thought is that patient can benefit immediately from lymphovenous bypass while waiting for lymph node transplant to work over time. So after a year or so, lymph node transplant can kick in, but meanwhile, lymphovenous bypass can provide our patients with some relief at the beginning, early on. And even if the patients cannot have lymphovenous bypass, they at least have had lymph node transplant, which potentially could help them. So I started doing this in 2013, so it's been over 10 years now, and then we published this, showing very promising result. This got the base paper award as well recently, and I presented this at a meeting in Chicago only a few weeks ago. So we will do the bypass, this study based on the indocyanine images that I showed you earlier. The lymph node transplant, different type of lymph transplant depending on the patient and the situation. And what we found is that this included both primary and secondary lymphedema, arm and leg, and this was from 2013 to 2019, over 300 patients. And patients, in all my surgeries, what I do is I ask patients to compression wrapping for 4 weeks. But after that, you are on your own. You can do whatever therapy that works for you. So there's no strict regimen that I do. So if the garment, if you no longer need the garment, you can start to wean off of it. If the pumping is needed, you can use it. So whatever works for you, you should resume that. And this is some data showing body mass index, that's the weight over height, 27. Average duration of lymphedema was 95 months. Arm was involved in about 60%, about 40% lower extremity. Most of the patients we saw were secondary, but some were primary. And we measured all the patients, the volumes before and after surgery. And we also do qualitative life scores to see if the patients feel their life is better after surgery or not. It's very important to know how the patients feel about their outcome. What we found is that the mean volume difference between the lymphedema and the unaffected arm, it was about 26%. So pretty severe, most of them. After 2 years, about 36% reduction. And I know that from the future studies that after 3 and 4 years, this continues to get better actually. And I'll show you that to you. And of course, the arm goes down more than leg, but much easier to manage for a number of reasons. It's not dependent as much, it's much smaller. And the secondary lymphedemas usually do much better than primary lymphedema. I think everyone agrees with that. And the quality of life score show that you can see significant improvement over time. So the lower it goes, the better. So at 3 years, 27.5 point lower. And again, the arm is better than the lower leg. Not much difference between the secondary and the primary. And close to 90% felt their lymphedema symptoms were better. There is a minority of people where there's no improvement or they felt like it was worse. So it's not perfect. Example, patient with a lymphedema, pretty severe of the left arm. You can see the ICGN showing very, very few functioning lymphatics. And here's a lymph node transplant. This is how it looks from supraclavicular area, put them into the axilla. Bypasses are performed, and this is 3 years later, almost 40% reduction. It's better than this, but not normal, okay? It's important to know. Another lymphedema of the arm, pretty severe. You can see lymphatic vessels, some are located here, top of her hand, pretty severe. I did lymph node transplants to the axilla. We did the 4 bypasses. Again, much better than this, but not normal, okay? It's never going to get perfect. It's just not going to happen. It just doesn't happen. So we found that the simultaneous approach, it can be very effective. So this is typically what I would offer patients, most patients. This is another study that was published in Annals of Surgery, just looking at secondary lymphedemas. And again, the data is well over, it's close to 300 patients. And what we see is that with only secondary lymphedema, you can see that at 2 years, 47.4% reduction in volume, and at 4 years, 47.7%. So what we wanted to see is the improvement that we see at these patients are not just temporary, but they are maintained over time, 3, 4, 5, 6 years later. That is what we want to see. We don't want them to look great for 3 months or 6 months or 1 year. We want patients to continue to have improvement over their lifetime. And this is the quality of life scores. Again, greater upper arm than lower arm, but continue to improve. This diagram shows essentially the volume reduction of the arm and the leg, and the fact that over time, the greater reduction is achieved. I'll just go through this quickly because of time. I want to leave enough time for question and answer. So this is quality of life scores, upper extremity and lower extremity. Over time, it continues to get better. Yeah, she's a nurse who used to get infections all the time, or had to be on antibiotics. And after the procedure, she no longer had to be on antibiotics, is off antibiotics, and is able to resume gardening and riding horses, and her quality of life improved significantly. Now, some patients who present like this, mainly fat at this point, are not candidate for the lymph node transplant bypass. For these patients, liposuction. But one thing we do have to make sure patients understand is that once you get liposuction, you're committed to wearing the garment around the clock. If you don't wear it, your lymphedema will come back. So that's not something you need to understand. So, and sometimes when you do liposuction, you have a lot of extra skin, and that really should be excised out. Otherwise, you'll just get filled in again. So if it's a minor liposuction, you do not necessarily have to cut the skin out. But if you do significant like this skin has to be probably cut out because it's not going to retract back in. So I do perform some liposuction selected patients. But if you are looking to not have to wear a garment, liposuction may not be the best solution. So it can be effective. And it can be combined with other procedures, and I do sometimes combine it. I do some limited liposuction in certain areas, and I have done that. Now, when you have lymphedema of this nature, you can't do any of these liposuction or lymph node transplant, then you do have to excise it, and you can skin graft it. So even though this looks like a severe burn scars, it certainly helped the patient to able to resume our life in terms of wearing the clothes, going to the work, participating activities. And again, this one all had to be excised and skin grafted. So these are some procedures that are performed depending on a case. And I just want to quickly mention that a lot of centers, including us, we've been doing this now for about 7 years. In patients who are having lymph nodes removed, we connect the lymphatic vessels at that time when necessary. It's called immediate lymphatic reconstruction to help prevent lymphedema. I know many centers are doing this. The original concept came from Italy many years ago, but the data was very preliminary. And this is probably one of the first publications from the United States. Again, the data was very preliminary, only very few patients. Follow-up was very short. So this earlier study from this group was very promising, and they published it. Now, the same authors, same patients, after 4 years, found that there was no difference between the lymphatic reconstruction group and the control group. So this has become somewhat of a controversy. Now, there's a lot of studies that are going to be published over the next year or two, which are going to be have a long follow-up, and we'll see. And our early preliminary result from Chicago is promising. In patients without immediate reconstruction in general, after actual dissection, the risk of developing lymphedema can range from 20 to 30%, even higher. In our group, where we did a immediate reconstruction so far, it's in single digits, so that's a significant improvement. But we will have to analyze it further before we publish it. Okay, and then some of the new things are out in the market now being used. BioBridge is a device that's made of collagen matrix. It's supposed to help with the lymphangiogenesis. It's supposed to help the lymphatic vessels grow out better. So this is something that is being used quite a bit in Europe right now, and I'm using it as well, particularly for a study. I have a NIH study with the prospective randomized study for patients with the upper arm lymphedema caused by breast cancer. And this is something that we are hoping we'll see it could help improve the effectiveness of lymph node transplant to help the patients. So it continues to evolve. Many questions, no cure. Early prevention, early intervention is the best solution. We cannot overlook the financial factor in this fight against lymphedema. It's a huge financial burden. A lot of insurances will not cover, calling it investigational and experimental, even though their publications have been published over the last 15, 20 years that are very scientifically sound. So I seem to spend more and more time with the insurance companies about this, because all my patients, for the most are go through the insurance process before having a surgery, because it can be a major financial burden for many patients. This is a study we published looking at this health disparity between about lymphedema surgery, and just like any other healthcare, we've noted that the patient with the lower socioeconomic status or financial status have less access to these procedures, and this is something that we need to be aware of. But while there are many challenges, there are also opportunities. It's opportunity for us to understand lymphatic systems better, develop better way to prevent and manage lymphedema. But what we need is a really good scientific data. We cannot just go based on anecdotal data. Oh, this worked for this patient, this worked for this patient. That's not science. We need the scientific data that shows long-term data, that the procedures that is verified by everybody else, so that if it works for me, other surgeons should be able to do it and get the same kind of result. If it only works for 1 or 2 person, like a magic, then it's probably not very scientific. So we need the prospective data, long-term outcome, and there's a lot of new technology that are coming into the lymphatic area now, using use of ultrasounds, MRIs, and then sorts that potentially could help us with this fight against lymphedema as well. So thank you so much for your attention. And now I will go and try to answer any of your questions there in the Q&A section. So I'm going to go from the top. How effective is lymph node transplant, LVT? So I don't know if that's transplant or bypass. Has for a long period of time, 50 years or more. So I'm going to answer that live. It can be, depends. Even if you had lymphedema for a long time, if you were able to maintain it well, we have found the patients to have a functioning lymphatic vessels and can be effective. So don't give up the hope. I would go seek your surgeon to see if you have a candidate. There's a question about a patient who had a lymphedema of the leg. Doctors don't know why. Long-term side effects since I have transplant kidney patient. Well, you can do diagnosis. You can, sometimes I have a lot of patients who have transplant patients who have lymphedema. I don't know if the growing lymph nodes are affected by it or not, but you can do a diagnostic testing such as lymphoscintigraphy to see if your lymphatic function is intact or not, or whether your swelling is from a venous problem or not. So you got to work it out. Just because you have swollen arm or leg does not immediately mean you have lymphedema. It could be venous issues or other issues. But so you have to do a diagnostic test when it's not clear what the diagnosis is. And then if you have lymphedema, then we gotta manage it appropriately. When you connect the lymph vessel into a vein, are there risks due to the fact that lymph fluid is not going through a node to cleanse or remove impurities? Well, that's a good question. But the lymphatic vessels, when they drain into the neck, but that's where they mainly drain in. But even throughout the system, believe it or not, that there are connections microscopically to the venous system. So there is some movement regardless, and they don't necessarily have to go through the lymph nodes. And we do not believe that the not going through lymph node actually is there has been no evidence to show that causes any kind of side of risks or side effects. So I have lymphedema in my arm due to breast cancer and level 1 and 2 nodes being removed. My lymphedema is between stage 0 and 1. Is there a particular stage where you do not recommend surgery, i.e. the lymphedema is not bad enough? I have been this way for 4 years, managed with. Yeah, if you can manage it very well, and if it's very mild, long as you can do that, then I think you don't have to have surgery. Surgery is not it's not going to cure, but the patients who are going to do well, the patients who I've seen where they no longer wear garment, are the patients who have early mild lymphedema, and you may not need lymph node transplant. But if you do a bypass and able to get that swelling down, it's possible that you'll be able to not become as dependent on wearing the garment as much or even at all. So if your lymphovenous bypass is done properly, so I would, for example, do an ICGN, and any lymphatics that are good would not bypass them. Only the ones that I see are obstructed, I would bypass. That way you're not causing any damage. Then potentially you could have a very good result. But if you're happy with what you're doing and your lymphedema is not getting better, then you don't have to have surgery, certainly not. Do you send your patients for complex kinds of therapy with the lymphatic therapy prior to surgery? What is your post-surgical recommendation? Well, absolutely. The reason is because most of my patients are not going to be cured of lymphedema. Okay, even if the surgery is successful, they're going to still have lymphedema, whether it's mild or not. So you have to still do therapy. So I want to make sure that patients develop a habit of doing the therapy on a regular basis, and then do the surgery, because you're going to have to continue to do it. If you don't do any of the therapy and expect a surgery to, if you just expect a surgery to give you significant improvement, chances are that's not going to happen. It has to be a combination. So surgery is just a part of the tool in the toolbox. All the other things continues to have to happen. But hopefully, if you get a good result from surgery, then maybe your dependency on these therapies may need to be reduced, and make your life easier. Maybe you will not get as much infection. Maybe you don't have to wear a garment all the time. Maybe only certain times, that sort of thing. So, and then certainly your lymphedema may not get worse, progress over time, which is a huge. So I think, yeah, I do have if patient comes to me and sees me and has not been to therapist or been to therapist years ago, but he's not wearing a garment or he's really worn out, I have him go back to see a therapist. I want them to get a new garment, get them all ready. It's part of getting ready for surgery. And after surgery, you continue to do it as needed. If you don't need it, that's fantastic. So I do have patients where they don't need it anymore, but I never promise that because I really don't know who that will be. But for the most part, you will have to continue to do the therapist, but hopefully to a lesser degree. I hope that answered that question. Somebody, yeah, could I talk possibly performing the surgeries you're speaking of in areas where fibrosis develop? Depending on how much fibrosis there is, if there's fibrosis is not going to just reverse itself. Even if do lymph node transplant and bypasses, fibrosis and fat deposition is not going to go away. That's why the arm and the leg is still big. Fluid might be out, but the fat and the fibrosis that has developed over the years are not going to be reversed. So your arm or leg might feel lighter. Maybe you can manage it better, but it's still going to be larger. That's why it doesn't go down. So fat can only be removed with liposuction. But if you do that, potentially you may have to wear garment more. So it's a bit of a trade-off. So tissue fibrosis are still going to be there. If it's very, very severe, like some example that I showed you, only way to manage it is excising it. But it's a big surgery. Scars don't look good. So you have to understand the fat and the fibrosis that has developed are not going to go away. It's just a fluid. Okay. So it's important to do the therapies and have the procedures done well in advance before the fibrosis develops. That's why I want to just emphasize early intervention. You need to get with a good therapist early on, educate yourself. And if you're going to consider surgery, have them done sooner rather than later before the fibrosis develops. Where does liposuction come into play? Well, again, you can do liposuction on any of the patients as long as there's a fat deposition. If there's no fat, if it's early on where you just have excess fluid, certainly it's not gonna. You don't need liposuction. But if you have excess fat, you could have this liposuction. Only thing is, and everybody who does liposuction will tell you this: if you do liposuction, you have to wear the garment around the clock. You might be able to take it off, take a shower. But if you go without it for a day or so, it's going to come back. So if you don't want to wear a garment, if you don't want to be dependent, then I would not do a liposuction. Where I do liposuction for me, and everybody's a little bit different. Some do liposuction first and do lymph node transplant bypasses later, or they do the same time. I generally do lymphovenous bypass and lymph node transplant first, and then all the fluid gets out. But if there's some fat deposition, many of the patients will just say, fine, I'm okay with it. But if you want that out, I can go do selective liposuction, those two small spots, not the entire limb. So that's what I usually will offer. But right now, there's no consensus on the timing of liposuction, when it will be, when the best time will be. Depending on the surgeon you speak to, they may tell you different things. So that's what I do. I try to give a bypass or lymph node transplant chance to be effective, and then do a little bit of lipo afterwards, if necessary. Because what we're trying to do is allow the patient not have to be dependent on garment as much, because nobody wants to wear a garment all the time. So I hope that answers that question. But there are some patients where I showed you where their limb is completely filled with fat, then the liposuction might be the only answer. How effective surgery for those born with primary lymphedema in one leg? Yeah, it's not as, so our data shows it's not as effective as secondary, certainly. So primary lymphedema is not as effective as secondary, and the leg is worse than the arm. Most primary lymphedema are in the leg, although I have seen patients with the lymphedema in the arm. So it is not as effective, but it can be. So I don't turn those patients away. I will still offer it to the patient if they understand that the potential benefit is significantly less than if you're secondary. So it is not as effective, but there's a chance it could get better. And I had patients where it get better. So as long as you understand that it can help you, but instead of being effective 75 to 80%, it's probably a lot less than that, maybe less than 50%. So it can still help depending on the case. A lot of questions about liposuction, which I think I already answered. How will the removal of the skin in type 2 and 3 lymphedema patients affect the healing time? Is it a hyperbaric oxygen chamber for faster healing? So I don't usually do a lot of skin excisions in these lymphedema patients, except for very severe cases. And hyperbaric oxygen, faster healing, well, it's controversial about that. I have never sent patients for hyperbaric oxygen. So this is not something that I do regularly, because I do think that patients don't like having big scars in their arms or legs, and lymphedema limbs don't heal as well as the non-lymphedema limbs. So I only do that for very severe cases. Are there studies, research ongoing currently to find a cure? Of course, a lot of research is going on, but I think the key is preventing lymphedema. Once the lymphedema occurs, the inflammatory process occurs, it's hard to reverse it. You can stop the cycle, but I don't think once your fat and fibrosis develops, I don't see how you could reverse all that. I don't, without actually removing it. It's not going to just all of a sudden fat and fibrosis are going to disappear and go backwards. So you got to stop that from happening in the beginning. I have heard that lymphovenous bypass is made to be redone over time as it becomes less effective. Is this true? And if so, how often does this happen? What is the average time it lasts for? I have never redone it. When I do it the first time, I try to do whatever I think is optimal. And so when patients come back, I'm not going to go back and all of a sudden you're not going to have a bunch of new lymphatic vessels that developed that needs to be bypassed. So I do not believe it needs to be redone. I don't agree with that statement. What is every time it lasts for? Nobody really knows. It could be lifetime. I have patients, I do it and they are great for their lifetime. There are some who where lymphovenous bypass may become not as effective over time. So there's no way to know how well the lymphovenous bypass are working 5, 6, 7 years later once the pressure gradient equalizes. That's why I offer lymph node transplant in addition, because the lymph node transplant it is not dependent on the pressure gradient. So I'm hoping that by doing two together with a completely different way of work of mechanism, that it could be complementary. Help answer to that. Now, I think we're out of time. So I know there are a number of questions here that I cannot get to. I really appreciate all of you for attending the symposium. And if you have any further questions, you can put the questions on the through the LE&RN, and I'll try to answer you if I could do that. Or you can reach out to the lymphedema surgeons or therapists nearby you. Thank you so much. Really appreciate all of you for attending. And I'd like to thank the LE&RN for hosting this.